So people have been asking me, what is a typical day in the life of a neurologist? So today is day 2 in the life of Dr. Miller, the brain doctor. The very first patient I saw today was a 27-year-old that I saw about 2 weeks ago. She was sort of dizzy and had some spells, and I wasn't totally sure. She was extremely nice. So I knew she wasn't faking, but her spells didn't really fit anything. So I did an EEG, a brainwave test, where we glue like 21 electrodes to the brain. They just sit in a comfortable lazy boy for about an hour. We listened to the brain. It was normal. So she came back a couple of days ago, was still complaining. So we had her sleep deprived. So I had her stay up all night last night. And we usually tell people to, do something until about 1, go midnight bowling or something, and then have another friend come at 1 and just watch movies, but don't let you fall asleep. And then we do it at 8 o'clock in the morning, the first EEG. She had an EEG. She was really tired, laid in bed in the recliner, and then we had her hyperventilated. Bam, she had a seizure. And she had this classic 3 to 4 hertz spike in wave activity and had some jerking, lost consciousness, and the technician shook her and woke her up. So she had this perfect 3 to 4 hertz spike in wave activity. You see with the absent seizures or petit mal seizures, and they as they get older will have grand mal seizures, and I bet this young lady has both. So I put her on a drug called Lamictal. She's very young and very safe in pregnancy and safe in breast milk. So that was the very first patient that I saw today. It was sort of fascinating. The second patient came in, and her doctor had sent her for neck pain and arm pain, and her hands are just completely going to sleep at night, just all 5 fingers. And he thought it was coming from her neck. And I looked at her MRI of her cervical spine. It was just normal, but I did nerve conduction, EMG studies. This is where we glue little electrodes to the skin, do stimulations, and measure the nerve conduction velocity. It's like in meters per second, but we think like miles an hour. And then I put little needles in the muscles. And so like the deltoid is C5, the biceps is C5-6, triceps C7-8, and so on. And her nerve conduction was terribly abnormal. She not only did she have carpal tunnel syndrome, but she had cubital tunnel syndrome. So she had the ulnar nerve trapped in her elbow and the median nerve trapped in her wrist. We've talked about both of these conditions before. Carpal tunnel syndrome is an entrapment neuropathy in the wrist. You have carpal bones and they form a tunnel, almost like my watch band is the top of the tunnel. And you go in there and cut off the top of the watch band and let the nerve breathe. Cubital tunnel is this tunnel in the elbow between these 2 bones. And there's usually a tendon, and I call it Mama Susie's gristle steak. The old cube steak we ate as a kid, you'd have to spit it out because it was so fatty and gristly. And you just cut that tendon and usually move the nerve out of the elbow in ulnar transposition. A lot of the doctors are just decompressing the nerve, but they always seem to come back and get the ulnar transposition. So this lady needs surgery. The third patient came in with hand numbness as well. And so I did a nerve study on them, and they also had mild carpal tunnel. It was just barely abnormal. There are 3 main segments, palm to wrist, finger to wrist, and then the terminal latency. And finger to wrist was just like very slow, like 39 meters per second. The other 2 are normal. So she's probably going to respond to carpal tunnel treatment conservatively. So I injected her wrist. I injected the flexor retinaculum in the wrist with some steroids. And I'm going to put her on some anti-inflammatories and some vitamins, and hopefully she'll get better. The next patient came in that had headaches, and this patient had 1 headache a month, severe, throbbing, pounding headache, no warning, nausea, vomiting, photophobia, so aversion to light, so had to be in a dark room, phonophobia, aversion to sound, and just be incredibly sick, and no neurological symptoms like numbness or weakness. So just a typical common migraine, and most people that have migraines have common migraines. And so I put this patient on just one of the triptans. I put this patient on Maxalt. So that sort of general rule, if you have 2 or 3 days a month ruined by headaches, I'll put you on a daily preventive. But just 1 headache a month or 2 or 3 that respond to the symptomatic treatment, then, that's just what we do. And so I put this patient on Maxalt. I could have tried any of the triptans, Imitrex, Maxalt, Relpax. I could have tried something like Nurtec, but something symptomatic to treat the headache. I saw another lady, very interesting, that she'd been having migraines for 30 years around her periods. perimenstrual migraine. Never had them, but usually began the day of her period or the day before. And I had her sort of go back and try to mark the day she had her period. They're pretty regular. So 3 months ago, I gave her Anaprox twice a day. It's like prescription strict naproxen. Began 4 days before her period, even without headaches. Anaprox BS, one twice a day, 4 days, to take to the last day of her period. And if she gets a terrible headache, Frova. It's one of the long-acting triptans, one twice a day for up to 3 days. Oh my gosh, it was a miracle. She only kept her appointment because she thought she had to. It just worked amazingly well after 30 years of trying everything. So that was another, great thing. And then I just saw a lady, oh my gosh, she was adorable. She had on all her Lily Pulitzer and bright colors and beautiful blue fingernails, and what an adorable 70-year-old lady, and just incredible personality. And she has been having a lot of numbness in her feet, a lot of stinging and burning in her feet. And I did nerve studies. She just had almost no potentials. So couldn't really get anything. The number one cause of neuropathy is diabetes. Number two is alcoholism. She didn't drink at all. She wasn't a diabetic. So she's going to get a big workup. We've talked about this in other videos, but I wonder if she has CIDP, chronic inflammatory demyelinating polyneuropathy. This is a chronic form. I hate to say chronic form of Guillain-Barré, the acute neuropathy, but it really sort of is. And they usually respond to IVIG. So we're going to do all the metabolic workup and check her hemoglobin A1C, her liver and kidney function, all her vitamins like B12, B1, B2, vitamin D, serum and urine immunoelectrophoresis, and then probably do a lumbar puncture. If her spinal fluid's protein's high, then we'll put her on IVIG. That's sort of interesting. Just something totally different. I saw another guy today. It's sort of been a really interesting day. That memory loss, and his B12 level was 100, and his MMSC, when I saw him the first time, was borderline, but MMSC, was just like 25. Anything under 27, I'm concerned about. And so we're treating with a B12, 1,000 units sub-Q weekly for a month and once a month for life. And, think about B12, we don't have the Schilling test anymore. The Schilling test, we gave a little pill of radioactive B12. You swallow it, and we measured in your urine for 24 hours. And I think if it's over 9% was in your urine, then we knew were okay. But if it was less than that, you couldn't absorb it. I don't remember the exact numbers because we don't do Schilling tests anymore because the little pill cost $1 and they got sued. Somebody said they got lung cancer from it and they pulled it off the market. So now if you're B12 deficient, you got to take shots for life. Or you can take the Nascobal, the nasal. And it doesn't matter what your B12 levels are. And big mistake we see, people are B12 deficient and then the levels are normal and they stop it. Well, it's just going to creep back down. So you have to take it for life. So hopefully his memory loss is from B12. I'm not sure it is with a level that low. Also, I saw another lady today, and 20-year-old, gorgeous, very thin, black-haired white girl. And she had arthritis, aching in her muscles, aching in her hands. This girl had no body fat. It tried to work out, didn't make her feel any better. Her vitamin D level was 18. And I told her about this New England patriot I saw a few years ago whose vitamin D level was 18. He was having the same symptoms, treated him with vitamin D. He's completely back to normal in about 9 months. And I really think she's D deficient. Number one thing we see with D deficient is arthralgias and myalgias, aching in the muscles, aching in the joints, and then numbness. See, a lot of these young people, particularly blacks and Hispanics, they have so much pigment where they can't get any D. And their hands will be numb and hurt. And then the nerve studies are totally normal, and they're severely D deficient. So I'd be willing to bet $1 million she's going to be so much better, and this is all that it is. And she'd had this just huge workup. So the last patient I saw was another patient with radiculopathy. He had neck pain radiating down to his thumb. And I looked at his MRIs, which were reportedly normal, and he had neuroframal stenosis C5-6. The thumb is C6. He's going to have surgery. This is not going to get better without surgery. So that's day 2 in the life of Dr. Caudle Miller, the brain doctor. A lot of people have asked me what my typical day is like, and so we're going to talk about day 3 next, when I have a day that's as fascinating as today. So like, comment, subscribe. I'll answer your comments. It may take a few days to a week, but I'll answer all the comments and more later.